Good morning, good morning. I think I'm live already, huh? Yeah. I think I'm live. I can see my face on Facebook, right? Yeah, on Facebook. So I don't know if you can see me. Can you see my video or something? I guess yeah. I think it's just kind of delayed. Okay, so here we go again. It's another Monday, right? For Connectics College. Good morning, everyone here in Texas. Can you see me and can you hear me there, guys? Can I get a yes so I can go on, so I can proceed? Good morning, good morning. I wanted to see the comments. It's kind of delayed on my Facebook. I don't know. Well, good morning, everyone here in Texas. Good evening back home in the Philippines, and happy Monday to the rest of our nurses across the globe, right? Because we are also live. I think yeah, we can also be seen by people by the nurses in the Middle East, even in Africa and in Europe, I guess. But I'm not really sure about the time in Europe though. But again, happy Monday to the rest of our nurses across the globe, aspiring USRNs, right? So once again, I'm Jay from IPAS Online Review and Mentoring Academy. We are tasked to discuss to you atrial fibrillation. It's a big topic. That's gonna be today. We're gonna discuss about that through Connectics College. Of course, it's every Monday, and we are tasked to do it every third Monday of the month. And I really thank Connectics for doing that in behalf of all the other, review centers giving free educations to our aspiring USRNs, right? And don't forget to also share, guys, before we begin our discussion. Okay, so share it to your Facebook page so it can reach, many nurses that are aspiring to be USRNs, right? So, our topic, atrial fibrillation. It's a common disorder, right? That you see here in the US. By the way, I'm situated here in Texas, like I said, particularly here in Beaumont, Texas, somewhere southeast, of Texas, near to Louisiana already, Louisiana border, Texas-Louisiana border. But anyway, atrial fibrillation is a major arrhythmia of the atria, particularly, that can potentially cause serious complications like clots into your brain, particularly your ischemic stroke, right? And so as other complications like congestive heart failure. Well, congestive heart failure can also cause atrial fibrillation. It's like a vicious cycle, though, right? So one can cause the other. So it's associated with each other. And again, like I said, it can particularly cause ischemic stroke, a clot into your brain. Sometimes I call it as your cardioembolic stroke, originating from your heart. If it says like, common here in the US, in the practice, that means, if this is a common disorder, it's a high yield topic also in your NCLEX. So be careful about these kinds of topics because it's really going to come out in your exam because again, it's a common disorder. Okay? So it could be in a form of case studies or in any formats uh like the traditional NCLEX. Case studies comes in three forms. Like the unfolding case studies with 6 questions each, and you're gonna get at least minimum of 3 case studies. That's all in all like 18 items, and up to 5 case studies. So that's a lot, guys, right? So that's a lot. So that's really the bulk of your NGN. Apart from your unfolding case studies, it can also be what we call as your bow tie. So it's based on a case scenario, and the bow tie format of question is like literally it looks like a bow tie, wherein you answer the diagnosis, where you answer the interventions, and probably diagnostic examinations related to that disorder. And again, based on the case scenario. So unfolding case studies with 6 questions, the bow tie, and standalone case studies. So everything about case studies, but we're not gonna discuss about case studies today. But we are going to discuss an important concept about atrial fibrillation. Okay, so without further ado, guys, okay, we'll discuss about your atrial fibrillation. Okay, so atrial fibrillation, like I said, it's a very common disorder here. It's an atrial arrhythmia that causes complications like clots into your brain. Okay, let's begin it with your conduction system. Okay, let me share my screen first. Okay, good morning, Miss Milanes, Miss Miel, Mr. Nasus, Miss Banji. Oh, thank you, Banji. Amber is also there. So a little shout out to you guys, Sheila. Before we begin, and like I said, please share it to your Facebook as well, huh? Okay, let me just. I think my Facebook is kind of delayed. Let me transfer it to my cell phone. Okay, hold on. All right, it looks better now. Yes, we can hear you. Miss Miel said. Miss Amber. So who else? Can you put your name on the comment section so I can see where are you at? Like, where you situated. I know there are also people from South Africa, from Middle East, our Filipino nurses in the Middle East, and some of them are not Filipinos as well, aspiring nurses in general, right? So I can see some comments here. Well, let me present hold on, my screen. Share screen. I guess this one right here. Already. Can you see my screen now? There, it's just kind of delayed, I guess. Okay, so let me start it off with your conduction system before anything else. Atrial fibrillation, right? So this looks kind of fancy, like my drawing. Well, we'll see what we can get here. So conduction system, the first thing that we're gonna discuss, so we can discuss more onto your atrial fibrillation later on, and of course, the ABCDs of your atrial fibrillation. I told you it's a common disorder. It's also a common thing in your NCLEX, especially in your case studies. Okay, it cannot only come out in your case studies, but it can also come out in other forms of items. The traditional ones um, like your SATAs and as well as your multiple choice. Okay, this is your heart right here. So this is your SA node. Let me put it in white. Are you ready, guys? Yes or no? Can I get a yes? From Ilocos? From where are you from? Miss Ria? Quezon City is Wina or Wena. Gemma is also from, I guess you are from IPAS Online, right? Miss Gemma, if I'm not mistaken. Well, we have a lot of students already, so I cannot really memorize all of you guys. Okay, so let me make it white. We good? Okay, good, good, good. So this is your SA node right here. SA node. SA node means what? Sinoatrial node. So sinoatrial node is your pacemaker, right? Your pacemaker. Your sinoatrial node, we're talking about conduction system, right? Conduction system. Conduction system. This is something to do with electrical impulses, coming from one to the other and then to the rest of the portions of your heart. Okay? So SA node is your sinoatrial node. It's considered as your pacemaker. It's able to propagate what? It's able to propagate 60 to 100 beats per minute. In a normal person, you should have 60 to 100 beats per minute. It's just right that your pacemaker is coming from your SA node. Sinoatrial node, from the word itself, sinoatrial, it's located in your atrial portion of your heart, right here. This is your right atrium, this is your left atrium, right? And this is your right ventricle, and this is your left ventricle. Those are the four chambers of your heart. SA node, electrical impulses coming from here, pacemaker, 60 to 100 beats per minute. 60 to 100 beats per minute is normal, okay? It's just adequate for you to have a good cardiac output. Remember, cardiac output is equal to what? Heart rate times stroke volume, right? So heart rate is a very important parameter of your cardiac output. Cardiac output is the volume of we discussed this one already last, a month ago. So cardiac output is just simply what you need from your heart, okay? It's a volume of blood ejected from your heart in 1 full minute. And the parameters are your heart rate, which is propagated by your SA node. That's why it's the pacemaker, and as well as your stroke volume. Remember, stroke volume is influenced by your preload, your afterload, and as well as your contractility. Okay, it's a parameter part from your heart rate to produce a good and adequate cardiac output. Okay, stroke volume again is influenced by your preload, your afterload, at the same time your contractility in order for you to have a good stroke volume. Okay? Normally, your heart rate is about 60 to 100 beats per minute. I'll just write 70 beats per minute. And your stroke volume normally is about 70 ml. When you multiply them, when you multiply them, you can have up to 5 liters of blood. Okay? 5 liters of blood circulating in the whole, cardiovascular system in 1 full minute. Okay? So 5 liters in 1 full minute. Cardiac output, how do you measure it? I mean, what's the simplest reflection of your cardiac output? Just take your blood pressure and that's it. Specifically, your mean arterial blood pressure or MAP. All right, your MAP. In other words, your MAP, your mean arterial pressure, is equal to your cardiac output. Mean arterial pressure is 2 diastolic blood pressure plus systolic blood pressure divide 3. Again, this is all we need from our heart. Okay? So we kind of segue a little bit from your conduction system to your cardiac output because your conduction system is very important for you to produce a heart rate and rhythm, which is again a parameter apart from your stroke volume in producing your cardiac output, which is simply what we need from your heart. Okay? The simplest reflection of your cardiac output again is your mean arterial pressure. All right? So let me see. Conduction system from the SA node, it gives impulses to your left atrium and at the same time your right atrium. Okay. So it travels here and into here we have what we call as your AV node. From the word itself, AV node. Atrioventricular node. Atrioventricular node means what? Atrio and ventricles. So this node is specifically located between your atrium and as well as your ventricles. So in the middle. That's why it's called AV node. Your AV node is only able to propagate what? 40 to 60 bits per minute. So there's really no way that your pacemaker is coming from your AV node because it's only able to propagate 40 to 60 bits per minute. Okay? So your AV node, yeah, I mean that the impulses travels to your bundle of His, okay, and into the right branch and into the left branch. We call them as your left bundle branch and right bundle branch, okay, and down towards your myocardium. I mean to your heart muscles. So in here we call it as your bundle branch. Bundle branch. We have the left and the right bundle branches, okay. These bundle branches can only also be able to propagate only about 20 to 40 bits per minute. Again, that's not good enough to produce a good cardiac output together with your stroke volume. Okay? Down towards the muscles in the septum and into the myocardium and to the rest of your heart. We call it as your Purkinje fibers. Can you follow? Purkinje fibers. Your Purkinje fiber, just like your bundle branch, it's only able to propagate 20 to 40 bits per minute, even lesser than that. Okay? So number one, let's review. Number one is your SA node. That's your pacemaker. Good thing about it is that, it's just right to be a pacemaker because it's able to propagate 60 to 100 beats per minute. In other words, pacemaker, the pacing begins from your SA node. Okay? We're not going to talk about the whole EKG here. This is just the basic, guys. Okay, down towards your SA node, it gives impulses to your right atrium and your left atrium. Forgive my voice because I just had a flu like a few days ago. So I'm just kind of like, catching up with my breath. So AV node. So it gives impulses to your AV node in the middle of your atrium and your ventricles. That's why it's called atrioventricular node. But it's only able to propagate 40 to 60 bits per minute. Okay? So bundle branch, there are two branches from the bundle of His. We have the left and the right, bundle branches. It's also going to propagate only about 20 to 40 bits per minute. It's very small, all right? It's a very small amount to produce as a parameter of your cardiac output, okay? And lastly, your Purkinje fibers. Purkinje fibers is the same thing, 20 to 40 or even less than that. The reflection to your EKG is looking like this. There you go. So this is your P, this is your Q, this is your R, this is your S, and this is your T wave, right? Can you see it? So your P wave, your Q, R, S, and then T. P wave is a little bit, I mean, it's a very small, like, spike. Okay, positive deflection, and this is negative deflection. When you say like positive deflection, it goes up. When it says like negative deflection, it goes down in your EKG paper. Okay, so your QRS is specifically your R wave is a little spiky towards up, and it's gonna be really quick. Okay, that's your R wave is actually your ventricular depolarization. Let's just label it, guys. So P wave. So P wave is basically your what? Atrial. Let's just abbreviate it. Atrial depolarization. When you say depolarization, it's basically a trigger to your contraction. Those are two different things. Okay? Depolarization and contraction are two different things. Depolarization triggers contraction. All right? Those are two different things. So depolarization causes what? Atrial contraction. So P wave is basically an atrial contraction. All right? Let's move on to your QRS. QRS complex. Okay. Your QRS complex is your ventricular. Oh, let me sorry, I forgot about your PR interval. Your PR interval, if you have an atrial depolarization, of course, it has to relax. All right? It has to relax. We call it as your atrial repolarization, your PR interval, sorry. Atrial repolarization causes what? Or triggers atrial relaxation. That's your PR interval. So we have the atrial activity here to both depolarization and repolarization. Okay? So let's move on to your QRS. QRS complex. All right. Right here, this is your Q. Let me put it in right. Q, R, and S. That's your QRS. QRS represents what? If you have atrial depolarization and atrial repolarization, you also have your ventricular depolarization. What did I tell you? Depolarization triggers your contraction. Those are two different things, guys. Okay? And lastly, your T wave. So if you have ventricular depolarization, which triggers contraction, you also have your ventricular repolarization, which triggers relaxation. Okay, so complete, right? Complete. We have atrial activity, depolarization and repolarization, which triggers contraction and relaxation. And lastly, your ventricular activity. Okay, so ventricular depolarization and ventricular repolarization as well, which triggers relaxation. So these are the things that you need to remember, right? So your P, Q, R, S, T. So in a normal sinus rhythm, right here, in a normal sinus rhythm before we arrive in your atrial fibrillation, and I'm going to at least tell you what are the common arrhythmias that we have. In a normal sinus rhythm, all right, but first thing, of course, you need to check if there is a complete PQRST. This is not an EKG class all the way, right? This is just a nutshell. All right. So check for the completeness of PQRST. In other words, the morphology. Okay. The morphology looks like this. The P wave is a little small, positively reflected. QRS is going up and down. All right. It's very quick because it's represented by time as well. And your T wave is a little bit elevated as compared to your P wave, but not necessarily picking up, leveling your R wave. Okay. Otherwise it's already hyperkalemia. That's another thing. The first thing that you need to look at, of course, is the morphology, PQRST. So this is number one. Secondly, we're going to look at measure the PR interval and as well as your QRS. PR interval represents the relationship between your atrium and ventricles. Okay? So that's why it's very important. Remember, P wave is about the atrial depolarization and R wave is included in your ventricular activity. So you're just simply measuring your atrio and ventricular relationship to each other. If it's more than 0.20 seconds, that means to say there must be something blocking along the way. So it means to say, it's kind of an AV block. If you have an AV block, of course, that means to say that you have an abnormal relationship between your atrium and your ventricles. That's why it's kind of prolonged. You get that? And as well as checking also your QRS. QRS is very important because that represents the ventricular activity. Mind you guys, the most important, activity, pumping structure of your heart is particularly your ventricles. And look at the ventricles right here. It's composed of large muscles, which is, again, contractility is a parameter of your cardiac output, which is really, really very important in producing a good cardiac output. Okay? So that's why we measure the PR interval, relationship between your atrium and ventricles, and as well as your QRS. QRS is the representation of your ventricular activity. If there's something wrong with your PR, your P wave, that's an atrial arrhythmia. If there's something wrong with your QRS, that's a ventricular arrhythmia. Easy, isn't it? Right? And the third one would be, this is just basic EKG. The third one would be checking the rhythm, if it's normal or not. Okay? Checking the rhythm. Checking the rhythm is, for example, this is your PQRST and another cycle here, PQRST. You just simply need to check the distance between one R wave to another R wave. If it's on the same distance, that means to say that's regular rhythm. If it's not, and then it's irregular rhythm. Okay, for a normal sinus rhythm, definitely, of course, the distance between your R wave and your another R wave to another R wave in a 6-second strips are what? Are the same in distance. That's why it's, normal in rhythm or regular in rhythm. And lastly, you measure the rate. Not the last one though, check the rate. And lastly, you interpret. All right? So what kind of rhythm is that? So this is your normal sinus rhythm. All right? Normal P wave, normal PR interval, normal QRS. There's no ST elevation or there's no ST depression. Okay? And normal heart rate as well, 60 to 100. So normal sinus rhythm. Okay. So let me tell you the common arrhythmias in the context of NCLEX. Let me put it in white. Okay. So arrhythmias is categorized into 3 major arrhythmias. We have the atrial arrhythmias, but I'm not going to discuss one by one. We have your ventricular arrhythmias, okay? And lastly, your atrioventricular arrhythmias. So this is basically your AV blocks. Okay, can you follow, guys? Are we good? So KG is also watching. Ronald is also watching here. Thank you for Ryan is also watching from IPAS Online, our energetic, educator, one of our educators. Hi, Rai. Are you in Cebu right now? Anyway, so let's continue. So we have 3 categories of arrhythmias. Okay, atrial arrhythmias, ventricular arrhythmias, which is far more, fatal than your atrial arrhythmias. But mind you, atrial arrhythmias are still atrial arrhythmias that can also lead into ventricular arrhythmias. So be very careful about that as well. And lastly, your atrioventricular arrhythmias. See, this is number 1, this is number 2 category, and this is number 3 category. Your AV blocks, let's start off with your AV blocks. These are the common arrhythmias. You can write it down, guys. These are the common arrhythmias in your NCLEX. Okay? They might ask you about this. So AV blocks comes in first degree AV block, second degree AV block, which is type 1 and type 2. Type 1 is also known as your Mobitz 1. Okay? And your type 2 is Mobitz 2. Okay? Your second degree AV block type 1 or Mobitz 1, sometimes we call it as your Wenkebab. Okay? Sometimes we call it as your Wenkebab. Okay, and lastly, your third degree AV block, or also known as your complete heart block. So there are 4 AV blocks that are considered as atrioventricular arrhythmias. Okay, something to do with the atrium and ventricles. Relationship between your what? P wave and as well as your R wave. I mean, your ventricles measured through your PR interval. So if you're going to measure the PR interval for an AV block patients, that's definitely prolonged because there's no good relationship between the two of them. Okay, so PR interval prolonged. Okay, first degree AV block, second degree AV block type 1, or also known as your Mobitz 1, or sometimes they call it as your Wenkebab, and second degree AV block type 2 or Mobitz 2, and lastly your third degree AV block or complete heart block. Take note of those things, guys, because it can be a hint what to study on your NCLEX. Let's move on to your ventricular arrhythmias. Most commonly your PVCs or premature ventricular contraction. Okay. And another thing is your ventricular tachycardia. We have so many types of ventricular tachycardia. It could be monomorphic, it could be polymorphic, which is more serious, of course. That's your torsades the point. I'm not going to discuss about that anymore. So these are the things that you need to remember. VTAC, there are many types, and the management is also different from each other, depending on the patient's signs and symptoms, if it's conscious or unconscious, depending on the clinical, picture of your patient. So we also have your ventricular fibrillation, right? PVC can lead into VTAC. Sometimes it can go directly to VTAC, or it can even go directly to your ventricular fibrillation, or even a systole, right? What I'm trying to say is that if you have premature ventricular contractions, we be very careful about that because it can be a precedent to a more serious ventricular arrhythmias. I told you, ventricular arrhythmias are more fatal than your atrial arrhythmias. Thank you for watching, Mr. Virgilio, Mr. Ronald as well. Okay, so ventricular arrhythmias, your PVCs. Okay, ventricular tachycardia. Okay, if you're not going to take care of your PVCs, it can lead into ventricular tachycardia. If you're not going to take care about your VTAC, it can lead also into your ventricular fibrillation. From the PVC, if the PVC is seen, and then, well, you have to be very careful about it, especially if it's 6 or more in 1 minute. You have to refer that to the physician. Kindly take note of the things that I'm going to mention at any time randomly, because those are the small little things that will come out in your exam. Okay, those are little knowledge that will, save you in your exam. All right, these are the common things. Ventricular arrhythmia. Let's go to your atrial arrhythmia. So before we can arrive with your atrial fibrillation. Okay, so atrial fibrillation, atrial arrhythmias. So PACs. PAC is premature atrial contraction. It's a common one, but it's not fatal. However, you still have to monitor your patient because you know what? PACs, or premature atrial contraction, can be a precedent to a more serious arrhythmias like any other arrhythmias. Okay, that's your PAC. And of course, the most common, which is your atrial fibrillation. Okay, we're gonna dig into this atrial fibrillation. This is the most common. All right, from the word itself, atrial fibrillation. Atrial, the arrhythmia is originating from your atria, right? Somewhere in your SA node, in your conduction system. Fibrillation means what? Fibrillation means there's no electrical impulses. So what does it mean if you have, no electrical impulses in your atria or fibrillation? Pathophysiology. Okay? So atrial fibrillation, another thing is your atrial flutter. Your atrial flutter. Okay. Your atrial flutter is not as common as your atrial fibrillation. Actually, they are treated on the same manner. Okay, they come in the same set of management. Your atrial flutter. Okay, so atrial flutter is characterized by sawtooth. You know that very well. All right, you know that very well. Atrial flutter, that's sawtooth formation. That's fluttering P wave. I mean P waves. All right, so atrial flutter. And lastly, your PSVT, or paroxysmal supraventricular tachycardia. Supraventricular tachycardia, which means to say it originates from your atria. So it's still, an atrial arrhythmia. By the way, if you look at the books, guys, don't call me out on this, all right? Don't call me out on this, or, don't get me wrong. Technically speaking, your atrial fibrillation, atrial flutter, and PSVT, Wolff-Parkinson-White syndrome, re-entry tachycardias, we call them collectively as your SVT. Okay? Supraventricular tachycardia. Supraventricular tachycardia is basically an atrial arrhythmia. It can be in a form of atrial fibrillation. It can be in a form of atrial flutter. It can be in a form of the PSVT itself, the paroxysmal supraventricular tachycardia. Okay, so that's SVT. So atrial fibrillation, the patient is having SVT. Is it like irregular rhythm? Is it like narrow complex? All of them are like with narrow complex because these are all atrial arrhythmias. However, atrial fibrillation is irregular in rhythm as compared to your PSVT and your atrial flutter most commonly. All right? So that's how to differentiate the SVTs. Again, atrial fibrillation, atrial flutter, PSVT are collectively known as SVTs. It just depends on the, the morphology of the PQRST, especially the regularity of the R to R interval or the rhythm, because it matters when you manage your patient, especially if you are delivering shock to your patient. Do you get that? It seemed kind of like heavy, but with repetition, with mastery of all these things, in cardiology, you will be able to make it. You'll be able to master it. Just understand the principles behind it, especially the most important things, talking about, for example, like atrial fibrillation. Just to review: atrial arrhythmias, PACs, atrial fibrillation, atrial flutter, PSVTs. Okay? Ventricular arrhythmias, PVCs, you have to take care of it. 6 or more, refer it to the physician. VTAC, we have many types of VTAC, and as well as your ventricular fibrillation. And lastly, AV blocks are considered as your atrioventricular arrhythmias, first degree, second degree, Mobitz 1, Mobitz 2, or Wenckebach. Your Mobitz 1 is Wenckebach. And lastly, your complete heart block, or also known as your third degree AV block. Come and join us in IPAS, and so I can, tell you about, how to distinguish between a first degree AV block down to your third degree AV block, and so as the other, arrhythmias. I do the, the discussions about cardiology, specifically on your EKG. I guess we in 30 minutes. Is it 30 minutes already? Yeah, it's 30 minutes already. Let's dig in about your atrial fibrillation. Okay, atrial fibrillation. I told you earlier. Okay, a little bit about pathophysiology here. If you have atrial fibrillation, what's the complication? What's the most common complication, guys? Come on. What's the most common complication if your patient is having atrial fibrillation? This is what you think, the patient can have this complication. Come on. That's why the patient must receive these kinds of medication, before we arrive with our management. Come on, come on, come on. All right. Thrombus formation. All right. This is your heart right here, for example. This is your heart. And then there's no electrical impulses. There's an aberrant electrical impulses in your, on your atria to both right atrium and your left atrium. This is very easy. The blood circulates from your vena cavas, your superior vena cava, and your inferior vena cava, right? It goes into your atrium, to your right atrium, and then it goes into your right ventricle, and it goes into your pulmonary artery, and into your lungs, getting or picking up some oxygen, and goes back to the heart, right? And then it goes to the left atrium, then left ventricle, it goes into the aorta for systemic circulation. So that's the circulation is all about. Now, if you don't have any electrical impulses in your atrium, what will happen to that blood? Remember, blood is normally viscous. It's a it can release, the platelets can actually release pro-coag chemicals that will lead into coagulation. Again, your blood is normally viscous. Try to get some blood from your patient and then put it on a certain bottle like this. It will coagulate right away. Okay, it will coagulate right away because it's naturally viscous. At the same time, it contains lots of pro-coagulant chemicals. In other words, chemicals that can cause or promote coagulation. So if it's static in your atrium, if it only stays in your atrium, it doesn't circulate because there's no electrical impulses there. There's no atrial activity, depolarization, repolarization. What will happen then? Okay, it becomes static. It will form coags. It will form, clots, and it can throw, clots everywhere. It can throw to your brain from your left atrium into your aorta, into the carotids, and into the cerebral artery. And from your right atrium, it can also throw thrombus to your pulmonary artery, which can cause pulmonary embolism. So it's really prone to clots. That's why you expect that your patient will get, your anticoags. Okay? And what else? So clots. Nice to see you here, Ma'am Gemma. Yeah. And yeah, Miss Mary said clot formation. And you need to control it, guys. See ha, you need to control it. You need to control the heart rate, because if you don't control that heart rate, higher chances of developing clots. You know why? Because once this SA node is kind of like really having trouble or problem, the AV node will take over. If the AV node will take over, remember, it can only propagate 40 to 60 bits per minute. If it takes over and the heart rate is just too much, it's not normal for them to propagate 60 to 100 beats per minute. So if it's taking over, it's a problem. It's just simply disturbing their normal environment, their normal functioning. So when your heart is like really quivering and then really fast in terms of, heart rate, it's gonna bring about like, more clots and more chances of throwing it to your brain. That's why you need to control the heart rate as well. Okay. So atrial fibrillation. So let me write it here. Your atrial fibrillation. Okay. So atrial, or can I just erase this one here? Oh yeah, I can just write it here. Atrial fibrillation. Okay, atrial fibrillation. So I guess I have some drawing here. There you go. This is what it looks like if you have atrial fibrillation. Can you see it? Yes or no? Oh yeah, the keyboard warriors in iPads. Anyway, thank you guys for joining us here. And well, this is the classic appearance of your atrial fibrillation. Let's justify it, right? So let's question: is there a P wave? That's the very first thing that you need to look up. All right, on an EKG rhythm, is there a P wave or no? Is there a P wave? Oh, questionable P wave. All right, questionable P wave. These are all erratic P waves. This, you are not sure that these are P waves. All right, so there's no P waves. I would say like questionable negative P waves. What about your PR interval? Of course, if you don't have a P wave, naturally you cannot measure the PR interval. So no PR interval. What about the QRS then? The QRS is there. Remember, this is an atrial arrhythmia. This is not a ventricular arrhythmia. Okay? So atrial arrhythmia. So there's nothing wrong with your QRS complex. Okay? So normal QRS complex. I'm not gonna talk about the time, because if I'm gonna talk about the time, then we can go back to our basics about EKG and measuring the time. So normal QRS, considering this is an atrial arrhythmia. All right? So no P waves, of course, no PR interval, and QRS complex is normal because this is an atrial arrhythmia. So the characteristic, let's see. The characteristic of your atrial fibrillation is what? So characteristic. There you go. So no P waves. So this is the number one characteristic. And secondly, irregular R to R interval. In other words, irregular rhythm. Okay? Look at the rhythm here. Again, no P waves, no P waves, no P waves. But look at the rhythm. How do you measure the rhythm on an EKG, tracing? Look. So this is your R wave, R wave, R wave, R wave, R wave. On a 6-second strip, this is 1, 2, 3. Yeah, that's 3, 4, 5, and 6 on a 6-second strip. Look at the distance between one R to another R. If you can make use of your caliper as well, it's very obvious. Even without using your caliper, you can really see that the distance between your R wave into another R wave is, irregular. So irregular, that makes your rhythm irregular. Okay? So no P waves and irregular R to R interval. Okay. So what are the types of your atrial fibrillation? Atrial fibrillation. Don't call it AF, because we used to call it in the Philippines AF, especially if you're working in ER and ICU. I worked in ICU before, we call it AF. But here, they don't understand if you call them AF. It should be atrial fibrillation. Okay, atrial fibrillation. So there are types, right? We have, the acute type and of course your chronic type. And in terms of the heart rate, we have 3 types. We have AFib and SVR. If you count the heart rate, guys, if you count the heart rate, counting a heart rate on an irregular rhythm, you just need to count how many R waves. 1, 2, 3, 4, 5, 6, 7, 8, and 9. So in this case, you just have to multiply it by 10 and you get the heart rate. So in this case, 9 times 10 is 90 beats per minute. So this is a case of your AFib in MVR. Okay, so AFib and SVR is less than 60 beats per minute. Okay, less than 60 beats per minute. SVR means what? slow ventricular response. What did I tell you earlier? If there's problem in your SA node, in your atria, which particular portion, takes over? The AV node. AV node, triggers impulses in your ventricles. So there would always be ventricular response. Okay? If there's a slow ventricular response, 60 beats per minute or less, that's a kind of an AFib with SVR, or slow ventricular response. Okay? We still have time, right? Oh yeah, we still have time. So AFib in MVR is controlled AFib, which is the heart rate is 60 to 100 beats per minute. Okay, 60 to 100 beats per minute. So we call them as your moderate ventricular response. So your AV node, your bundle of His, your Purkinje fibers are not stressed out in compensating for the missing action in your atria. That's what we want, all right? But I'm not telling that AFib is still good though, but because it's controlled, but AFib is still AFib. But at least it's controlled as compared to your AFib in RVR. Sorry, my voice is really something. Rapid ventricular response, which is more than 100 beats per minute. We don't want that because we call it sometimes as your rapid AFib, right? Rapid AFib. That's why you need to control the heart rate. Okay? We don't want that because, again, your AV node, your bundle of His, your Purkinje fibers, in your ventricles are only designed to produce on a certain amount, propagate, certain amounts of heart rate. And if it's already like more than 100 beats per minute, okay, chances are you are also, throwing more clots to your brain because it's very fast. And does it compromise your cardiac output? Definitely yes. It doesn't mean that your heart rate is elevated. It doesn't mean that your cardiac output is high or adequate enough. No, it's not. It's just simply what? Too fast. If the heart rate is too fast, whatever, atrial fibrillation, whatever, ventricular tachycardia, whenever it's too fast, what will happen to your ventricular stretching, or to your ventricular filling? It's lesser chances of stretching as well. If it has lesser chances of stretching as well because it's too fast, what's going to happen to your ventricular filling? Lesser ventricular filling as well. Lesser ventricular filling means what? That's basically your preload. Lesser, stroke volume as well, because it's just too fast. It's just quivering compared to a normal individual, which causes you to have like a good stretching of your heart. A good stretching of your heart muscles causes you to have a good ventricular amount of ventricular filling. And remember Starling's law. The moment that your heart is going to stretch that far, it's also going to forcefully contract. That's Starling's law. If it's going to forcefully contract, the good thing about it is that it can cause you to have a good ejection fraction into your aorta and good oxygenation to your brain and to the rest of your organ system. All right? That's the very problem in your tachycardias. All right? Because it has a lesser chances of stretching well, lesser chance of stretching well, lesser chances of ventricular filling, lesser cardiac output. Even if your heart rate is, high. We don't want that. We just want normal heart rate and we just want normal stroke volume. Okay? So we want to control the RVR. All right? So I told you, anticoags and as well as your heart rate control. So let's take a look at your ABCs. I guess I don't have time to, discuss the action potential, depolarization, all those stuff. These are actually the basis of your medications. This is a good foundation of your medications. Let's just talk about your ABCDs of your atrial fibrillation in terms of management. All right, management, A, B, C, D, and E. You just have to remember this, management, A, B, C, D, and E. Regardless of what kind of atrial fibrillation is that, you have to, consider this management. In other words, this is a general management of atrial fibrillation. Okay, so letter A stands for what? Letter A stands for what? For those of you who are from my class. So what is letter A in your atrial fibrillation? The ABCDs, guys. What is letter A? What is letter A? So do I have to repeat the types of your AFib in terms of the heart rate? If it's controlled or uncontrolled, SVR is slow ventricular rate, which is less than 60. MVR is moderate ventricular response, which is 60 to 100 beats per minute. And lastly, your rapid AFib, or also known as your rapid ventricular response AFib, which means your heart rate is more than 100 beats per minute. Anticoags, very good. Anticoags. We have many types of anticoags. You don't need to necessarily give heparin IV, all right? Heparin is, yeah, heparin is an anticoags. Okay, you can give subcutaneous, all right? You can also give PO in a form of your direct acting anticoags. This is the common ones. Direct acting anticoags. How do you spell it? Direct acting. Direct acting oral anticoagulants. There you go. There you go. So direct acting oral anticoagulants. These are your PO. So your heparin is, when you say like sub-Q, that's your low molecular weights. Okay. It's either the two of them. Give me the two, subcutaneous low molecular heparin. We have your enoxaparin, and as well as what? Enoxaparin, and the other one. The other one is your, what's the other one? Your Arextra. Oh, what's the generic name of your Arextra? Come on, guys. What's the generic name of your Arextra? All right. Generic name of your Arextra is Fundaparinox. There you go. I think I got it. Fundaparinox. Okay. Between the two of them, these are both subcutaneous. But you know what? Enoxaparin, lesser chances of developing your heparin-induced thrombocytopenia. Fundaparinox, sorry. It's the other way around. Enoxaparin has a higher chances of developing heparin-induced thrombocytopenia. It's a complication related to your heparin, wherein your antibodies are formed, which causes you to have consumption of your platelets, causing you to have thrombocytopenia. And together with that antibodies and your platelets, they will produce pro-coagulant chemicals that will later on paradoxically causes, DVTs, pulmonary embolism, even stroke, serious forms of clots. Okay, so HIT is also a kind of not really a trending, but it can come out in your exam as well. Again, HIT is heparin-induced thrombocytopenia. It's usually related to your heparin administration. It's an autoimmune disorder that wherein your antibodies are produced. It will, fight your platelets. It will consume, thereby causing thrombocytopenia. But the fighting between your platelets and as well as your antibodies causes you to have chemicals produced, which will, promote coagulation, DVT, pulmonary embolism, like I said. So the good thing about fundaparinox is that lesser chances of HIT. That's another knowledge, guys. Okay, you don't need to give an IV heparin because you're just simply putting your patient on high risk for bleeding. So your direct acting anticoags, your heparin, and direct acting anticoags, your PO, in a form of your, for example, like your rivaroxaban, okay, and as well as your apixaban. These are the common ones. So you expect, if your patient has a chronic AFib, it's been diagnosed already. Be careful if you have new AFib, new onsets of AFib. You really have to refer it to the cardiologist. It's a new onset, so chances are it will really develop some clots into your brain, for example. So if you have chronic AFibs, expectedly your patient will get this, anticoags, rivaroxaban and your apixaban, or apixaban. All right, rivaroxaban or apixaban. Rivaroxaban is, I guess, I think it's Xarelto, and apixaban is Eliquis, right? Of course, your NCLEX not gonna get you. It's not gonna test you with a brand name. They're gonna test you with generic name. But guys, sometimes they will also give you some form of a brand name. It's just random, right? And as well as your vitamin K antagonist, right? Your vitamin K antagonist. Okay, that's the mode of action of another PO anticoags, which is your Coumadin, or also known as your warfarin. Okay, warfarin. Which is better, rivaroxaban, apixaban, or warfarin? I would go with direct acting oral anticoags because warfarin is kind of like, really, you have to be very meticulous because you need to check for the INR, for example. Rivaroxaban, it's readily available. It will act immediately as compared to your vitamin K. At the same time, you don't need to check for the coags factors of your patient, like INR, PTT, and all those stuff. Heparin is PTT. Vitamin K antagonist or warfarin is checking about your INR. In here, you check for your PTT. And in here, I'm just going to emphasize on this one, heparin. Especially if it's in a form of IV. Okay, but in a form of sub-Q, you don't need to do it. Okay, you have to have a baseline, but you don't need that. You don't necessarily monitor the patient's PTT. All right, not unless if it's an IV form or unfractionated type, not the low molecular type. Vitamin K antagonist, the PO warfarin. The bad thing about it is that compared to your direct acting oral anticoag is that you check for INR. Okay, it has to be like the magic figure is like 3 in order for it to become therapeutic. And so much to learn about this, warfarin. Okay, so that's another topic, guys. So anticoags, heparin, direct acting oral anticoags, and vitamin K antagonist. Okay, another A is your amiodarone. Okay, your amiodarone. Your amiodarone is also known as your antiarrhythmic, specifically known as your potassium rectifier. Okay, I don't have time to really discuss about your action potential for you to understand these medications. Amiodarone is a type 3 kind of antiarrhythmic medication wherein it rectifies your potassium. What do you mean by rectifying potassium? It's usually given on a cardiac arrest with ventricular arrhythmias, having no pulse. All right, so amiodarone. Potassium rectifier. It tends to like, hey, potassium, come here inside. Come here inside. Normally, your potassium is inside the cell. This is your cell. This is your potassium right there. It tends to go out if your cardiac myocytes and as well as your nodal cells are activated. All right. So I need you to come back here. So that's potassium rectifier. Okay. So potassium rectifier is again your amiodarone, just like your adenosine. It tends to, hey, potassium, come here inside. So it promotes repolarization. When you promote repolarization, you're also promoting relaxation of your heart. That's why it can decrease your heart rate. Can it decrease your blood pressure as well? Yes, it can decrease your blood pressure. Antiarrhythmic medication can cause what? Decrease in your blood pressure. Because, the action is into your cardiac myocytes, into your nodal cells, which primarily lessens your heart rate. It lessens your contractility. It lessens your cardiac output. Remember, consistent with your MAP, it also decreases your blood pressure. Okay? So that's your amiodarone. So that's another A. So A here and A here. All right. Amiodarone is usually given during cardiac arrest with no pulse and having, ventricular arrhythmia. So let's go to your letter B. Okay, letter B is what? Come on, guys. Miss Richelle is asking about action potential. Anyway, so letter B is what? Letter B. Come and join us in IPAS. And then you can probably next time I can discuss about more about action potential and all those stuff. Beta blockers. Okay, beta blockers. Okay, your beta blockers. These beta blockers is of course beta blockers. It blocks your beta 1 particularly. Okay, beta 1 is the beta 1 are the receptors. These are the receptors. Okay, these are the receptors wherein your norepinephrine will bind. Okay, in your cardiac myocytes, there are only two cells in your heart: your cardiac myocytes and as well as your cardiac, your cardiac nodal cells. If your norepinephrine, a byproduct of your sympathetic nervous system, okay, if your norepinephrine binds to your beta 1 receptors, it causes you to have increased heart rate. Okay, again, sympathetic nervous system response, your norepinephrine binds to your beta 1 receptors, particularly in your nodal cells and as well as your contractile in your cardiac myocytes. It will bring about, particularly in your nodal cells, it will bring about increase in your heart rate and increase in your contractility, right? So, in a patient having AFib, with RVR, what's gonna happen then? Rapid ventricular response, increase in your heart rate. So you block this mechanism from happening, your beta 1 receptors and your norepinephrine, and you're also lessening your heart rate as well. We call it as your chronotropic effect. If you're lessening your contractility, we call it as your what? We call it as your negative inotropic effect. So decreased heart rate and negative contractility. Beta blockers are particularly an antiarrhythmic medication. It somehow causes decrease in your blood pressure. In fact, it's classified as an hypertensive medication. However, it's the least potent, but primarily as an anti-arrhythmic medication, decreasing your heart rate and rhythm at the same time, decreasing your contractility. Negative inotropic effect and negative, chronotropic effect as well. It can also decrease in your, lessens your dromotropic effect. The conduction system velocity will also be decreased. So that's dromotropic effect. So much to learn, right? So anyway, that's your beta blockers in a form of your what? In a form of your metoprolol. Okay, metoprolol. There you go. So metoprolol, that's the common one, right? So be very careful because there's also non-selective type. For example, like carvedilol. Carvedilol is non-selective not only to your beta 1, but at the same time to your beta 2, including your alpha 1. So your carvedilol, it's a very common medication as well, right? Carvedilol blocks your beta 1, blocks your beta 2, blocks your alpha 1 in your blood vessels. So it's also a blood pressure medication. The thing is, if you're also blocking your beta 2, it tends to disturb, your bronchial muscles there, so thereby causing what? Asthma. And so as, or triggering asthma, and so as with your other non-selective beta blockers. Did you get that? All right. So normally what we give is your metoprolol. If your patient is during acute, presentation, you give IV because PO will take time to be absorbed. So we have IV and your PO. All right. So letter C. Let's just finish the A, B, C, D, and then we're done, I guess. So letter C is what? Calcium channel blocker. Okay, your calcium channel blocker. Calcium channel blocker has two forms. The non-dihydropyridine. You don't need to memorize this stuff. The non-dihydropyridine and as well as your dihydropyridine. I guess I can extend, right? The non-dihydropyridine and your dihydropyridine. If you are talking about arrhythmias, we are not dealing with your dihydropyridine, with your pins. So be very careful about this because there are two types of your calcium channel blockers. All right. For example, like amlodipine, these are primarily for blood pressure. Okay. On the other hand, when you say like non-dihydropyridine, this is more onto your heart rate and contractility. In other words, it's an antiarrhythmic medication. Okay. In a form of what? In a form of your diltiazem or your cardizem. And what's the other one? Verapamil. All right, your verapamil. Diltiazem and your verapamil. These are what we call as your non-dihydropyridine. So it has a negative chronotropic effect, negative dromotropic effect, decrease in your AV conduction system, velocity, all right, and negative in your inotropic effect. So everything is negative. Chronotropic effect, dromotropic effect, and inotropic effect. In other words, decreases your heart rate and rhythm. And it causes you to have a normal rhythm. However, it decreases your heart rate. It relaxes your heart. It decreases your inotropic effect. In other words, decreases contractility. It simply relaxes your heart. That's your diltiazem and your verapamil. And again, this is different from your calcium channel blocker, which is your dihydropyridine, because dihydropyridine is more specific to your blood pressure. Okay, so that's your dihydro, your pins, amlodipine, nifedipine, and all those stuff. Let's move on to your letter D. Well, your letter C comes in there's also one letter C here. Calcium channel blocker and your catheter ablation. Catheter ablation. So it's basically indicated for patients who have chronic AFib, wherein, ablation is like freezing. It's like an extreme temperature. Hot temperature and a cold temperature, like freezing the part of your atrium that causes you to have AFib. For example, this one right here. So there's some form of like a re-entry circuit here that's causing the AFib, for example. So they're gonna put a catheter inside your aorta. It's an arterial approach, or it could also be like a venous approach. So it's done in your heart catheterization lab. So it tends to what? It tends to freeze by a cold temperature, extreme cold temperature, or hot temperature, to dissolve those spots in order not to cause atrial fibrillation to that particular area. in order to normalize the the conduction system, the electrical impulses that is causing your atrial fibrillation. That's catheter ablation. It's a pretty common procedure here. It's like a heart cath. All right. So same as with your heart catheterization, I'm talking about your nursing care. Okay, so that's letter C, calcium channel blocker and catheter ablation. Let's move on to your letter D. Letter D is your digitalis, right? We're almost done. Digitalis, right? Digitalis. Okay, digitalis. Or your digoxin, your brand name. So much thing about, your digitalis in terms of nursing care. Of course, you check for your heart rate. You can never give your digoxin if it's, if your heart rate is less than 60. All right, because if you think about it, it has a negative chronotropic effect, negative dromotropic effect, which means decrease in your heart rate, decrease in your AV conduction velocity. And the good thing about this one as compared to other medications is that it has a positive inotropic effect. In other words, increase in your contractility. Okay. The bad thing about your digitalis is that digitalis toxicity. Okay, digitalis toxicity. It's very, it has a very high therapeutic index. We're in when you say like therapeutic index, higher chances of being toxic to your patient. Okay, the normal levels of your. This is another thing. If your patient is taking, this is the last resort, by the way. If your patient is taking digoxin, okay, you always have to monitor for the digoxin levels. All right. I guess the value is about what's the value here? 0.8, 0.8 to 2.0 nanogram per ml. So that's the normal therapeutic level of your digoxin. Other than that, if it's more than 2.0, please check. Nursing intervention here is to check for NAVDA, NAVDAX, right? Nausea. This is nausea, all right? This is abdominal pain. Okay. This is your vomiting. So it's more of like GI if you think about it, right? And this is your diarrhea. This is your anorexia or loss of appetite. Again, this is more of like GI. And xanthopsia. Xanthopsia is something to do with the vision, blurring of vision. If your patient is having some blurring of vision, that's a sign of your digitalis toxicity. All right, and please be very careful about checking your potassium as well, because hypokalemia can actually exacerbate, if my word is right, can actually trigger. I think that's the safe term. So hypokalemia can trigger digitalis toxicity. And remember, anything to do with therapeutic levels, you also check for what? You also check for your BUN and creatinine. It's just, your kidneys are the ones who will eliminate the excessive amounts of the toxic effects of your medications. It's just right for you to check your BUN and creatinine. Okay? So that's your letter D. Let's move on to your letter E, right? Letter E is your electrical cardioversion. There you go, electrical cardioversion. Cardioversion. Electrical cardioversion is indicated especially for emergencies, all right? Actually, we have two, all right? We have your elective one, which is done for chronic patients, and the other one is for acute patients having rapid ventricular response. You cardiovert your patient if your medications are not working, or if your patient is already losing your pulses. In other words, your patient is already unconscious. You do your electrical cardioversion, having AFib, atrial fibrillation. So negative pulse is definitely, that's already your cardioversion. So AFib without pulse, cardioversion, right? Cardioversion. So well, it's it's irregular, so it means to say that it's a higher dose, but not necessarily defibrillation. So that's a separate topic though. Right? For chronic patients, they tend to have elective cardioversion. When you say like elective cardioversion, you need to schedule it on a later time because the patient is having chronic AFib. So, chronic AFib is indicated with elective cardioversion. So what's so this is your elective cardioversion. Okay, you're just simply cardioverting your atrial fibrillation, because again, your patient is really high risk for developing clots, CVA stroke. All right, so make sure prior to this procedure, elective cardioversion, okay, it's usually done as an outpatient. It depends. If your patient has a lot of comorbidities and needs to be like high risk, it needs to be admitted, especially if you have a lot of complexities. I'm talking about comorbidities, guys. But normally it's done as an outpatient. You check for patients are to be undergone with TEE. TEE is also known as your transesophageal endoscopic transesophageal endoscopic visualization, not really visualization, but you need to check for clots if there are already developed clots in there. It's like an echo, all right? This is the invasive version of your 2D echo, because your 2D echo is also known as your transthoracic endoscopic procedure, your TTE, transthoracic. In other words, you're just simply using your skin in your thoracic area, and then you're done, right? So with the use of your transducers. But in here, this is TEE. TEE is invasive, all right? So I'm just gonna put here invasive procedure, wherein you are going to insert an endoscopic a scope into your esophagus. That's why it's called like uh, endoscopic echocardiography. All right, so it's an invasive one. It goes into your esophagus and then try to check if there's any clots into your heart. It's just adjacent to your heart anyway. All right, to check for the clots, because we wanted to make sure that there's no clots evolving there. Because once you do your cardioversion, once you shock your patient, so this is just basically shocking your patient. If you're shocking your patient, it may throw thrombus to anywhere, to your pulmonary artery or to your brain. That's why it's very important for you to check for clots using this procedure, which is your what? More specific, your transesophageal and endoscopic, echocardiography. That's your TEE. That's the invasive version of your TTE, or transthoracic echocardiography. All right. And make sure also, guys, that your patient will get an anticoags. Okay, anticoags times 4 weeks. All right, probably in the form of your direct acting oral anticoags like your apixaban and your rivaroxaban. Okay, this is your ABCDEs of your AFib. Let me just review a little bit. Atrial fibrillation, you think about clots that goes to the brain or pulmonary artery, which is very rare. Most commonly, it's your stroke, ischemic stroke. We wanted to prevent some stroke, also known as your cardioembolic stroke, coming from your AFib. Atrial fibrillation. Atrial fibrillation, there's no electrical impulses in your atrium. If there's no electrical impulses in your atrium, what will happen? Your blood is normally viscous. What will happen? It will create clots, and it will throw, clots to your brain coming from your left atrium. Or if it's coming from your right atrium, it can go to your pulmonary vasculature, causing what? Pulmonary embolism. So the management are what? Prevent clots. Secondly, to control your heart rate. In a form of anticoags, amiodarone, for example, to control your heart rate. Beta blockers, most of the time, that's what we're giving, because amiodarone is usually given during arrest, no pulse with ventricular arrhythmias. Okay, and that's letter B, your beta blockers, particularly blocking your beta 1 receptors, your metoprolol. All right, it's more onto an antiarrhythmic action rather than your blood pressure, the least potent blood pressure medication. All right, but be very careful, because if you're giving some form of non-selective beta blockers, it can select beta and beta 2, which is present in your respiratory system. It can trigger asthma, just like your carvedilol. Letter C stands for calcium channel blockers. Calcium channel blockers, specifically your non-dihydropyridine, diltiazem, and your verapamil. You always see this to your patient having AFib and some forms of ventricular arrhythmias. I don't care about your dihydropyridine, because these are pins. These are particularly for your blood pressure, because it doesn't act in your heart. It mainly acts to your what? To your blood vessels. I'm talking about non-dihydropyridine, right? And another letter C is your catheter ablation. By putting some extreme temperature there, hot or cold. Most of the time it's cold, like to again to kill those uh, irregular impulses there in your atria. Letter D stands for digitalis, but be very careful because digitalis has a toxicity. That's why it's a last resort. Your nav ducts, these are the signs and symptoms of your toxicity, and be very careful also. You have to check for your therapeutic level 0.8 to 2.0 nanogram per ml, and check for potassium because potassium can potentiate. There you go, that's the word. Can potentiate, your digitalis toxicity, and also check for your binding creatinine because these medications can kill your kidneys just like other medications. And lastly, your electrical cardioversion. And that's the topic for today. Any question, guys? I don't know if I can, discuss some case studies. I just find it like, uh, I know you've been having so many drills about case studies, right? If you're enrolled in a review program, of course, for sure, you have so many drills like us. We do it like weekly or every after the discussion about cardiology, and then the day after or before the end of the week, we do our drills, and including the case studies. And I'm just saying that it's very important for you to have a good concept before you answer any types of questions. Whatever types of questions they're gonna ask you, as long as you understand what is AFib, as long as you understand, what is a beta blocker is, what is an amiodarone does, I think you're good to go. All right, you're good to go. In other words, you're not gonna have hard time answering any types of questions. Guys, trust yourself, you can do it. Trust God, and everything will follow. See you in the next month, I guess. Yeah, after another 4 weeks of time. Time is really running so fast, right? And let's discuss another topics or concepts. Thank you, guys. Thank you, and God bless everyone. Thank you. Thank you.